Headaches. How many times have you heard somebody say, "Oh, I've got a migraine"? Do they really? Do they know how debilitating a migraine is? Do they know the definition of a migraine? Which leads me to the differential diagnosis of different types of headaches. You've got cluster, tension, and migraines. Wait a minute. Differential diagnosis, what type of a question am I going with here? Case study, matrix grid, 100%. Patient presents with ... signs and symptoms. When people say, I've got a migraine, and they're able to say, I've got a migraine, and they're sitting there doing one of these, they don't have a migraine. What they've got is a tension headache. So what are some risk factors, select all that apply, of tension headaches? So things like sinus issues, dehydration, stress, caffeine withdrawal, so on and so forth. So again, these are things that can be resolved. So how do I treat it? Well, treat the underlying cause. You got stress, get rid of the stress. You got caffeine withdrawals, well, tough it out so you don't have them anymore, or give yourself some caffeine. So dehydrated, drink some fluids. Tension headaches are going to be something that's bilateral. They're probably going to last about 30 minutes to about 4 hours. That's your time frame. But treat the underlying cause. And it's going to feel like a band around your head, like somebody's putting pressure all around your head. And how are we going to treat it? Well, NSAIDs, acetaminophen, analgesics, right? So ultimately, treat the underlying cause, and if you need something a little bit more, we've got some pharmacological intervention there. So your basic care and comfort for this individual is going to be treat the underlying cause, hydrate, caffeine, so on and so forth, relieve stress, rest, or we can give them NSAIDs, acetaminophen. The next one is what we call a cluster headache. A cluster headache is typically going to be seen in males, and it's going to be unilateral, and it's going to be around the eye, and it's going to be a sharp pain that happens at the same time every single day. This one lasts 15 minutes to 3 hours. And with this, we can use one of our triptan drugs, so something like sumatriptan. So cluster headaches, again, a differential diagnosis between tension, which is going to be your more common one, when people are like, oh, I have a migraine. No, you don't. You've got a tension headache. Cluster, more significant, seen in males, and again, same time around the eye, 15 minutes to 3 hours, but we need to treat this with sumatriptan. Now we get to what is a migraine, what people think they're having, but they're really not, unless they truly know. When you've had a migraine, typically you've had a history of it, and it's recurring, or it can be triggered. So migraines are debilitating. People don't understand how sensitive you become to sound and light. So photophobia, phonophobia. It's going to be unilateral, and it's going to last 4 hours up to 3 days, 72 hours. This person's going to want to sit in a dark room, a dark, quiet room. So those of you that have ever had a migraine, which I haven't, but I've treated patients with it, they're not going to want to leave that dark room. And in this situation, again, our option pharmacologically is going to be sumatriptan. We can also use acetaminophen and NSAIDs simultaneously. But with the pharm portion of this, what we want to know is that we can prophylactically treat this. So once a person gets a migraine, we know that they're going to get it again. It's just inevitable. At some point, they're going to get triggered, or it's just going to happen. And now we want to prophylactically prevent it. And what's a great drug, a cardiac drug, you wouldn't think is used for neuro, but a cardiac drug that we can use prophylactically for that migraine? Beta blockers. So beta blockers prophylactically, like a propranolol, metoprolol, atenolol, you can give it prophylactically in order to prevent migraines from happening. So when we think about beta blockers, what are we thinking? Bronchoconstriction contraindication, bronchospasm contraindication. So what? COPD asthma. And remember, beta blockers do what? They lower blood pressure, lower your heart rate, even though we're using it prophylactically for migraines, but know what they really do. So if we give too much of it, look for them to become hypotensive and bradycardic. So side effects of beta blockers. Never forget those because beta blockers are super, super high yield. And again, we can use it prophylactically for migraines. So the differential diagnosis here is cluster, unilateral, same time, typically in males, treated with sumatriptan. Tension, which is typically what we talk about when people are like, oh, I got a migraine. And these ones are going to be things like stress, dehydration, caffeine withdrawal, so on and so forth. And what are we going to do? Treat the underlying cause. If we need, we can give analgesics. And then the last one is the actual migraine, which is debilitating. 4 hours to 3 days. Photophobia, phonophobia, meaning I don't like light, I don't like sound. And we're going to treat them with sumatriptan, NSAIDs, acetaminophen, and then prophylactically we can give them beta blockers. So know those differential diagnoses. It's a great bow tie question, a great case study, or a great select all apply. I mean, I can ask it in 100 different ways. So know those inside out because they're super high yield. Why? They're common. Common medical conditions are high yield. So again, super high yield. Hope you enjoyed.